You can start your session now.
A warm welcome to you for this experience sharing program on managing PPH. It's brought by Heathrow Healthcare. Heathrow Healthcare, as you know, has got 25 years of excellence with 300 plus products in portfolio, 36 state-of-art manufacturing facilities and 21,000 employees globally, and we are amongst the largest manufacturers of FDFs and ARVs in the world. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation. To welcome to this experience sharing program, we have got Dr. Priyanka Dubey with us. Welcome, madam. Madam is
Thank you, sir.
MBBS DGO, consultant obstetrician and gynecologist, trained in USG, trained in basic infertility IUI, and trained in fertility enhancing surgery. Over to you, madam.
Thank you, sir. Thank you for a warm welcome. And good evening, everyone. And once again, sorry for this inconvenience. Today, we will be discussing about overview of postpartum hemorrhage. As we are already late, so I'll go little fast. PPH is a very common problem still after development of so many drugs, but it can occur even in women who are not at risk also. And PPH is leading cause of maternal mortality in low income countries and the primary cause of nearly 1/4 of all maternal deaths globally. So what is PPH? PPH is a loss of at least 500 ml blood following vaginal delivery or either cesarean section, vaginal delivery, and 1000 ml following cesarean section. Next. Coming to the postpartum hemorrhage, it is very unfortunate problem, but yet it's very common also because it is one of the most important cause for maternal mortality, leading cause, and it accounts for 35% of all maternal deaths. Maternal mortality rate in developing countries was 2040 per 1 lakh live births compared to 16 in developed countries. And it is globally 14 million women suffers from PPH. Incidence of PPH is reported as 2% to 4% after vaginal delivery and 6% after cesarean section. PPH incidence is 38% of maternal deaths are due to PPH only. 25.7% of global deaths take place in India, and 2/3 of these attributed to PPH. So India has an unexpectedly high maternal death rate that is 540 per 1 lakh live births. Etiology of postpartum hemorrhages. Either it may be because of less tone in uterus, or either because of any coagulopathies, because of trauma or any tissue. So when the uterine atony occurs, that is inability of the uterus to contract while which may lead to continuous bleeding. And if there is any coagulopathies in the patient where the blood is fails to clot, then it leads to PPH. If during either during vaginal delivery or in cesarean section, uterine trauma or any injury to birth canal, rupture of uterine rupture or uterine inversion or laceration, it leads to PPH. And if there is retained products of placenta in any mode of delivery or any clots or abnormal placenta, it may lead to PPH. How we will diagnose clinically whether the patient is in PPS? On clinical examination, the abdominal tenderness will be positive, circulatory collapse will be there, like BP will be low, and pulse will be feeble. Increasing abdominal girth, if we will measure, loss of uterine contraction, patient uterus will be tonic, or maternal tachycardia or vaginal bleeding will be the positive cause. On the basis of this clinical findings, we can assess the degree of shock. If the blood loss is 500 to 1000 ml and there is no change in blood pressure and symptoms will be only palpitation, dizziness or tachycardia, the body will compensate with this much of loss. But if the blood loss is 1000 to 1500 ml, slight fall in BP or weakness or sweating, tachycardia along with palpitation and dizziness, it may alarm you for mild degree of shock. If 1500 to 2000 ml of blood loss is there, or marked fall in BP and restlessness and pallor and oliguria will be there, it indicates moderate degree of shock. And if there is blood loss is 2000 to 300 ml, profound fall in BP or collapse, air hunger and anuria will be there, then it is severe shock. How will postpartum examination, first initial evaluation, how we will do? First, rapid assessment of the patient's status, then presence of tachycardia and hypertension we should look for, or assessment of vital signs like a pulse, BP, or blood loss will be measured. Then examination at the time of hemorrhage. Assessment of the entire genital tract should be there for any laceration, hematomas, or blood clots, or any signs of rupture or cervical tear might be in the case of normal delivery. On manual examination for written products of tissue, we should assess or assessment with bedside ultrasound to check if the uterus is non-contracted or is there in any bits of placenta will be retained, or evaluation of uterus to check for uterine inversion. Coming to laboratory tests, complete blood count should be checked, hematocrit or platelets, and a coagulation profile should be done for assessment of any fibrinogen or coagulopathies. How we will approach towards postpartum emergency once it is occurs? First, we have to assess whether it is because of poor uterine tone or because of any trauma or tear or because of retained tissue. If poor uterine tone is there on abdominal palpation, we should feel uterus feels relaxed and boggy or soft. Atonic, it may on fundus may be felt above the umbilicus, so abdominal girth will be increased and uterine cavity is filled with blood and clots. Full blood count, coagulation profile, urea and creatinine we should, and electrolytes will be sent. If patient is not responding to fluid and any blood replacement, abdominal ultrasound bedside should be done to know about the rupture or any intra-peritoneal bleeding. For poor uterine tone management, we should give oxytoxics, prostaglandins, ergot alkaloids, either one or two in combination, or uterine balloon tamponing can be done. Hemostasis algorithm, for that we should see the articles and the protocol. We should follow the stepwise. If surgical interventions needed, we can go for that. If tears or trauma will be the cause, then on clinical findings, we will see the bleeding from trauma site or from the genital tract. Uterine rupture might be the cause. Extension of uterine angle during cesarean section or tears during cesarean section might be very common. Extragenital causes in that, such as subcapsular live rupture or rupture of ovarian or splenic vessels is one of the cause. And in normal delivery, there might be cervical tear is most and the most common in our day-to-day practice, which we are getting from referred cases also. In this case, investigations will be first we should inspect the cesarean section site and by exteriorizing the uterus. Our ultrasound may help identify the free fluid in patients with uterine rupture. Management, we have to repair of the identified genital tract trauma, whatever is the cause, we should repair it. And on pelvic artery embolism is the one most last, if all measures fail, may be required in case of broad ligament or supra-elevated hematoma. Last and most common cause is retained tissue. If retained placenta or membrane will be there, we have to identify by bimanual examination. And examination anesthesia we should do for that confirmation. And management is we have to remove the placenta or the retained product of concession under general anesthesia or regional anesthesia. For that coagulopathy, if coagulopathy is a cause, then after doing all these measures and we will not find any cause, what we have discussed before, then we may think about coagulopathy because continuous bleeding will be there and with contracted uterus. So we have to think about that. And in that case, urea electrolytes, full blood count, and coagulation profile, we have to get it done. And medical management, it includes immediate replacement of blood and coagulation factor and platelets, whatever comes in the reports. And on surgical interventions only with trauma or atonic hemorrhages, unresponsive to any medical treatment, we should go for that. But if the attempt should be made, yeah, if attempt should Carbetocin. So nowadays carbetocin. Next. So nowadays carbetocin is available in a room temperature stable formulation and convenient vial presentation. Here we will show why we need this carbetocin has come and how it is better than oxytocin. Oxytocin and any other ergot aldehydes that should be kept in refrigerator to avoid any degradation. It should be maintained for 2 to 8 degrees Celsius, and heat stable formulation of oxytocin is currently not available. And in some resources poor countries where the cold chain is not maintained and transportation and storage is capacity is very low, there oxytocin is not useful. So because of all these drawbacks, we need a room temperature and heat stable formulation. Because carbetocin is stable at room temperature, its shelf life is 24 months and at 30 degree and 75% humidity. It avoids need for any cold chain storage and logistics and is provided in a vial form. Uh, how we before using any utrotonic agent, we should first keep in mind when we should administer it. So the time of administration is at the crowning of baby's head, at the delivery of anterior shoulder, at the end of second stage of labor, and following the delivery of placenta. It can be used for prophylactic prevention for PPS and active management of third stage of labor, and therapeutic disease management of PPS. So these are the following molecules available as a utrotonic agent like oxytocin, carbetocin, ergometrin, symptometrin, and misoprostol. Carbetocin, this is a next generation drug for PPS, and it is nothing else but it is a drug which is synthetic long acting analog of oxytocin, and it was created by making several modifications in the chemical structure of oxytocin structure which make it more useful for prolong it, which helps in prolong because of that its half life is prolonged, and it reduces the enzymatic degradation of carbetocin. So its therapeutic indication is prevention of postpartum hemorrhage due to uterine atony, and it is 1 bar contains 100 microgram of carbetocin, and 1 ml solution for injection is ready over 1 minute. Slow IV we can give, so it will be more effective. There are many clinical data are there where trials have done. In that, here there is a comparison between oxytocin and heat stable carbetocin. Coming to the description, oxytocin is synthetic cyclic peptide form of the natural occurring posterior pituitary hormone. It binds to oxytocin receptor in the uterine myometrium, stimulating contraction of this uterine smooth muscles by increasing the solution as by increasing the sodium permeability of uterine myofibrils. And intravenous use, if we are doing, almost immediate action is there with peak concentration after 30 minutes. And on IM injection, the action is slow, but it takes 3 to 7 minutes, but produce a longer lasting clinical effect up to 60 minutes. Half life is 1 to 6 minutes. But in case of heat stable carbetocin, it's a long acting synthetic analog of oxytocin with agonist properties. It binds to oxytocin receptor in the uterine smooth muscles, and it also causes repeated rhythmic contraction, which increases the frequency of existing contraction and increases the uterine tone. But on IV, the sustained uterine contraction will be within 2 minutes, and it lasts for about 6 minutes, followed by rhythmic contraction, continues for 60 minutes. On IM, the uterine contraction lasts for about 11 minutes and rhythmic contraction for 120 minutes. Half-life of carbetocin is 40 minutes. Coming to storage and transportation, as I told before, also oxytocin requires 2 to 8 degree for continuously cold chain maintenance. But this is carbetocin is heat storage. We can transport and keep it at highest 30 degrees centigrade also. And other clinical indications are oxytocin can be used for induction of labor, augmentation of labor, for prevention and treatment of PPS. But carbetocin is only used for prevention of PPS. Carbetocin, WHO champion trial has been done, and it has shown carbetocin is non-inferior to any oxytocin, because this is a study which is the largest clinical trial in the prevention of PPH, and the trial conducted by WHO Department of Reproductive Health and Research, and the study design was non-inferiorly double-blind randomized trial. Objective of this study is to compare the effectiveness and safety of investigational heat stable carbetocin to oxytocin in the prevention of PPS after vaginal birth. The 30,000 women across 10 countries, including India, was enrolled for this study, and the outcome was the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents, and the proportion of women with blood loss of at least 1,000 ml. The in that study, the parameters are blood loss more than or equal to 500 ml or the use of additional uterotonic. With carbetocin, the efficacy was 14.5%, with oxytocin 14.4%. Blood loss of more than equal to 1000 ml, in that the efficacy with carbetocin was 1.51%, but with oxytocin it was 1.45%. At least one unanticipated adverse effect was noticed, and with carbetocin this A was 4.9%, but with oxytocin it was 4.7%. At least one severe and serious adverse event was there, that was with carbetocin 0.7% and with oxytocin 0.6%. So the frequency of the expected adverse events did not differ significantly between the two groups. So the frequency of blood loss of at least 500 ml or use of additional uterotonic agent with carbetocin was proven to be non-inferior than oxytocin, and the use of additional uterotonic agents in interventions to stop bleeding and adverse effect did not differ significantly between the two groups. So conclusion was carbetocin was not inferior to oxytocin for the prevention of blood loss at least 500 ml or the use of additional uterotonic agent. There was a Cochrane review that was also study was done, and carbetocin for preventing postpartum hemorrhage. In this Cochrane review, data from 11 studies involving 2,635 women were included, and the author concluded that for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPS for women who have vaginal deliveries and is associated with significantly fewer adverse effects. Different guidelines are there for the use of carbetocin for prevention of uterine atony, and there are several societies and like Societies of Obstetrics of Gynecology of Canada, Mexican National Center for Health Technology Excellence, Danish Society of Obstetrics and Gynecology, expert group of the Polish Gynecological Society, Philippines Obstetrics and Gynecological Society, Chinese Society, and Ministry of Health of the Russian Federation. They all have different recommendations how and when we should use carbetocin for the prevention of uterine atony. According to WHO 2018 review, only one of the drugs should be used for prevention of PPS, that is carbetocin, because this is only for prevention, not for treatment. According to SOGS Canada, 100 microgram IV bolus carbetocin should be used for that prevention. Ranscock New Zealand Society, active management of third stage of labor, prophylactic uterotonic should be used. According to FIGO, carbetocin is the drug, one of the recommendation for PPS management. Germany, Austria, Swiss body, they have also recommended carbetocin 100 micrograms slowly IV. And according to FCOG France Society, carbetocin on proving non-inferiority to oxytocin, it is achieved by champion trial. Here there are some my experience with carbetocin. Initially when it came, we were also thinking whether to use or not, and with IV or IM there was a big confusion, but nowadays I am using, and this is the one case whether I have this 27-year-old primary patient referred from periphery to me after trial of labor, and when she came, cervix was 5 centimeter dilated, and it was a case of prolonged labor. As patient told, more than 2 days she was admitted in the periphery, and on USC, there was a loop of cord, there was no liquor was very scanty. So I recommended, already it was late for cesarean section, and the baby weight was 4 kg. So in my opinion, in view of prolonged labor, before only I decided to give carbetocin, and it was a good experience, and there was no PPS, and patient and baby was fine. In second case, a patient, gravida 2 para 1 living 132 years patient came to me with previous vaginal delivery, where after taking history, she told she had excessive blood loss and she had 2 or 3 pint of blood transfused. So I guess it was a history of PPH in first pregnancy. So beforehand only I gave carbetocin prophylactically in this patient, and in this patient it was uneventful. And third case is a primary gravida, 29 years old, history of preeclampsia and raised liver enzyme, underwent vaginal delivery. In view of risk of PPS, I gave carbetocin prophylactically, and it was very helpful because initially after giving carbetocin, because on table only I thought bleeding because there was no tear, nothing what I guessed, and bleeding I amount was little bit more. So I just instead of giving oxytocin, I gave carbetocin only. For 5 minutes, it was okay. After 5 minutes, again, I thought again increasing the blood loss. But again, after waiting or massaging uterus, no need of giving any other uterotonic agents. With carbetocin only, uterus was contracted and patient was fine.
Thank you very much, madam, for your feedback and for your experience, sharing your experience. I'm sure
Thank
the
you, sir.
audience would be. And one question, madam.
Yeah.
What was the route of administration that you used commonly?
Sir, IV over 1 minute, slow IV.
IV or very slow IV?
Yes.
As a
Initially, sir, initially, actually, you are very experienced. I was very happy that you will moderate this session because I have also many doubts, and I thought I will ask you because initially when it came, we were very scared whether this new drug, if will give, whether how much it will work or not. So I asked hetero people also, but IM we were giving initially because here senior
yes,
ma'am also they were giving IM whenever we are asking in CMEs,
correct, correct,
they are
correct.
telling ki no IM we are giving, we are not giving at all. Still some ma'am are there, they are not using at all. So it was a very doubt whether we should give or not, but
It's
I started giving IV.
yes, yes, yes. It
So
can be given
response is good.
either. Yes, it can be given either IV or IM. In fact, that's the advantage of the drug or oxytocin. In the interiors where you don't have ICV facilities many times, this IM route helps.
Yes, sir.
And which is
Sir,
coming, yeah, madam.
yes, sir, tell
Yeah,
me.
coming to these questions, what is the patient profile where doctors can anticipate PPH?
Sir, if in one case I told if there is a prolonged labor and patient was in labor for a long time, more than 24 hours or 30, if multiple gestation is there, multi-para, instrumental delivery wherever like forceps or ventouse we are using, or in sometimes big babies are there, and in cesarean section, I hope we should give.
Yeah, not to take chance. Maybe
Yes, sir.
patients with fibroids also they are more prone.
Yes, sir.
In which
Sir?
patients would you prefer carbetocin over oxytocin for prevention of PPH? Specifically,
Uh, sir, in all cesarean section, in my
or cesarean
experience
section.
nowadays, I am
Okay,
giving all cesarean
correct,
section. I am
correct,
giving,
correct, correct, correct.
and yeah, previous history of if PPH is there, a patient
PPH.
is telling in any mode, ki, like I had excess bleeding loss. So whether they will not tell it was PPS, but we can guess and we should give prophylactically for precautions.
In fact, any patients whom you expect or anticipate PPH, you will prefer carbetocin. That's correct. Can we use carbetocin? Your experience, madam, in case of retained placenta, after of course removal of placenta.
In retained placenta, sir.
Yeah.
Sir, yeah, in retained placenta, I got one case after 12 days she came, but in
Oh,
that 12 days, continuously she was bleeding because she was a
correct,
poor patient, poor profile, and
correct.
she came like bleeding is not going. And after that, I checked the all profile and ultrasound I did, and because her per abdomen was around 20 weeks.
Oh, oh, oh,
Then I
oh.
told ki after delivery also this much is their height. So I just guessed it might be something
Retained
is there
placenta.
inside the
Okay.
uterus.
Yeah.
So and ultrasound there was written bits of placenta. I stable
Okay.
the patient. Patient hemoglobin was 5. I arranged the blood, and after that I gave carbetocin once in one only one patient I have given because she was bleeding profusely. After that under anesthesia I just removed.
Oh, and then the whole thing stopped.
After that,
After removal. Yeah, yeah,
yeah,
yeah.
after removal it was normal bleeding and
It's excellent.
nothing
This is
was.
excellent, madam. I mean, excellent experience,
Yeah,
I
thank you,
mean,
sir.
I'm sure the audience would benefit out of it. क्या होता है, our own doctor's experience is more important than what is written in the textbooks.
Yes, sir. Yes, sir.
Yeah,
Yes, sir.
that's very
That's
important,
why,
which is
sir,
why
I
we
was
are doing.
happy. Like,
Yeah,
with your
which,
experience, I will just,
yeah, yeah,
I
which
will.
is why we are sharing. All the
Yeah,
doctors
every
will
doctor
benefit
has
out of
different,
it.
different
Absolutely,
experience.
absolutely,
Yes, sir.
absolutely. Can you use carbetocin in your experience in Rh negative mothers?
Sir, yeah, that question I was thinking. I have given, but I should give or not, this type of any
There is
studies or
no,
trial I'm
yeah,
not
yeah,
doing.
there are no, in fact, there are no specific
Mm,
mentions of
yeah,
this,
sir.
which is
Yeah,
why
I
you go
also
by doctor's
searched.
experience, correct?
Yeah, but I have given in
Yeah,
three,
but,
four
yeah,
cases I have given and there was
and
nothing and it was fine only.
and this could be a big issue in the interiors, Rh negative
Yeah,
bleeding,
yeah, yes, sir.
blood, etc. Yeah,
Yeah, we are in very rural area. You can see
correct,
it's a
correct,
very
correct,
small
correct,
place where I am
correct.
working.
That doesn't. Yeah. Can it use doctor use carbetocin for prevention if oxytocin is used for labor induction?
Yes, sir. We should use because
Yes,
carbetocin is not for induction, not for augmentation. Oxytocin can be used for all these things, but carbetocin is only for prevention, whether oxytocin is
prevention,
used for labor or not.
correct. Now you're using IV almost everywhere, but
Yes, sir.
is there a place for iron?
Yes, sir. Actually, we can use IV or IM wherever we want uh, fast stability in the uterine contraction. If the uterus is atonic, so it's better to give IV route because onset is very fast and it will sustain for long. IM, the onset is very means slightly slow,
Slightly slower.
but it will long for duration. Yeah.
Correct, correct. Other uterotonics, if carbetocin doesn't work.
Other uterotonic once or twice after giving carbetocin also for prophylaxis or
PPH.
which you can say कि डर से पता नहीं फिर से हो जाए
नहीं
तो
बराबर.
sometimes infusion oxytocin I have tried
Okay,
multiple
okay.
because still we can't say कि with carbetocin only we are
No,
protected
madam,
fully.
I tell you, we have to use everything, it's a PPH.
Yes, sir.
What are the advantages specifically of carbetocin over other uterotonicks? Of course, there is no, heat stable,
Yeah,
etc.,
heat is
etc., etc.
stable and it is
Yeah,
stable carry to storage and transportation is very yeah. Onset
single
is
use,
good.
yes.
Yeah, and it's available in vial to carry करना भी easy है. So
Yeah,
that's
correct.
what.
And I suppose another big advantage, especially in our countries, IMUs or as well as IVUs, looking at interiors, those don't require a refrigerator. With
Yeah,
IMUs,
yeah.
many of the
I am
doctors,
using sir.
yes, yes,
Carbiac
yes,
I'm
yes,
using.
yes,
Carbiac
correct.
I'm using. Yeah, it's good.
Should carbetocin be kept as a reserve drug?
No, sir. It should not be
No,
kept for reserve. It should be used for prophylactic. If you want to use, you have to use first carbetocin only. After
correct.
using anything, and then if you
Then
are
there is no
using,
point. Yeah,
yeah, no point.
use the best now. Benefit as well. You have to use the best.
Yes,
That's the correct.
yes,
What's
sir.
the role of anesthetist?
Sir, this question actually in that I share with my representative of hetero once
Yeah,
because
yeah, yeah,
once there was a webinar like this only with anesthesia,
yeah, yeah,
obstetrics,
yeah.
and
Correct,
surgeon.
correct, correct.
I think you might be there in that. So
Yeah,
that I asked this question also because when initially it has come and I told my anesthetist, sir, you please give
yeah,
carbic after
carbidopa.
yeah.
Correct,
But he told, madam, ये necessary है. Is it necessary to give? Why can't oxytocin? Then I asked, no, nowadays it has come. It's better to
correct,
take
correct, correct, correct,
precaution.
correct, correct, correct.
Then he told, no, ma'am, with one doctor I gave this and there was a hypotension and patient was serious, something he told.
Okay.
So because of that, I shared this hetero people also. In that
Okay.
webinar also, I asked this question. Is it so because anesthesia was there? But here also I discussed with my anesthesiologist and then he told, no, and after that, that anesthetist only he is giving. But I told sir, hypotension might be because of some other problem also because patient might be for long fasting
Yeah,
and
yeah,
they have
yeah.
not given fluid before surgery. So
Correct,
might be
correct.
the cause. But
And
I
it,
searched.
huh.
So I think I am giving and anesthesia people will better answer this question
Yes,
if
correct,
they
correct,
have
correct.
any this
Experience
thing.
on this.
Yeah.
Overall, we had a wonderful webinar. Overall take home message for the audience.
Yes, sir. Now I will just tell, as we all know, PPH is still a very nightmare for all gynecologists. In spite of coming very powerful drugs, if the carbetocin has also come, but still 1, 2%, 3%, in all cases, we are scared of getting PPH. So, but after so many companies has come with this drugs, the incidence of PPH is definitely it has reduced and maternal mortality is also reduced, but we can't say we will not get PPS after using carbetocin. So we should be precautious. One thing I should tell, if you want to use carbetocin, you have to use as a preventive drug, not after using all uterotonics agents. First, you use this, you will have the good, better experience because it is a heat stable, easy to store, easy to carry, transport, and at room temperature also it is better, and it has better mode of action. It is fast acting. Other uterotonics better than other uterotonics because it's fast acting and its half life is also more. So it will maintain the sustained rhythmic contraction of the uterus. It's not like it will contract and then again it will relax. So it will continue that rhythmic contraction. Because of that only, it is better than other uterotonics and it will contain the sustained uterine contraction and it will stop the bleeding. So, but one should always keep in mind one thing only: for prevention, carbetocin is there, not for treatment. And after using everything, you should not go for this. You use first carbetocin, after that all. And sir,
Madam,
if your experience, anything you want
Madam,
to,
thank you
I will
so
just.
much. I mean, thank you so much. It was wonderful. The most important part is your experience, answering these
Yes,
questions.
sir.
I'm sure this your experience, sharing your experience has benefited the audience. I'm very sure about it. Thank you so much. It was a
Thank you,
pleasure,
sir.
it was a pleasure attending this meeting and sharing this screen with you. Thank you so much. And I thank the entire team of Hitro, IT team, marketing team, and sales team for this coordination and arranging this webinar. Madam, thank you so much, and thanks all the audience
Thank you, sir. Thank you so much.
who took
Thank you,
time
sir.
from their
And
schedule.
once again, sorry. Once again, sorry.
No,
We
no,
said
no,
there
madam,
was some
please don't say sorry. Please,
inconvenience. There is
it
a network
happens.
issue, and
It
suddenly,
happens. It
yes, sir.
happens in
Yes,
our place also. No worries, madam. And the network can go off anytime. Listen, अपना हाथ में नहीं है.
that's
Don't worry
it.
about it. Don't worry. Thank you
Thank you,
so
sir.
much. Thanks.
Thank
You
you,
can
sir.
sign
Thank you for
off.
the
Yes.
cooperation. Okay. Thank you, sir. Good
Thank
day, sir.
you.
Goodbye, sir.
You can
Thank you
sign
once
off,
again.
madam.
Yes, sir. Thank
Thank
you
you,
once
ma'am.
again, all hetero team. Thank you, Vibhashu. Thank you,
Thank you,
Sanjana,
ma'am.
and everyone who all have joined. Thank you so
Yes.
much for patient hearing. Thank you so much.
Madhu,
Goodbye.
Thanks,
it
madam.
was excellent and